Well, colleagues, friends from around the world, it's a great privilege to welcome you to the second of our series on the NSOAP manual. A warm welcome from Geneva, Switzerland, and United Nations Institute of Training and Research, and the Global Surgery Foundation. And we're quite pleased today to have Operation Smile and Johnson & Johnson's as co-sponsors of this wonderful series, and of course the Harvard Program in Global Surgery and Social Change that really spearheaded the effort in developing the NSOAP manual. So we have a great lineup of speakers today speaking on the first-hand experience of developing an NSOAP in their own country. And without any further ado, I'd like to turn it over to Ruben Ayala from Operation Smile, who is going to serve as our moderator. We'll hear a few presentations and then go into a question and answer. And please feel free to use the chat option and then later the question and answer option. So Ruben, thank you very much, and I turn the floor over to you.
Thank you, Jeff. Good day, everyone. And really, once again, thank you for joining us in the second webinar series dedicated to building resilient health systems through national surgical, obstetrics, and anesthesia plans. We really do appreciate, Jeff, the work and the invitation by UNITAR, Global Surgery Foundation, the work of Harvard's Program in Global Surgery and Social Change, and the support of Johnson & Johnson towards this series. And today also the opportunity to have Operation Smile join in support of this webinar. As you mentioned, Jeff, that we have a truly incredible roster of individuals who have firsthand experience. So I'm not going to spend much time saying anything else that will take away from their opportunity to speak with you. So without further ado, I'd like to welcome our dear friend, Dr. Lubna. And Dr. Samad is a consultant pediatric surgeon and the director of the Center on Essential Surgical and Acute Care at the Indus Hospital and Network in Pakistan. In addition to clinical pediatric surgery, she's fully committed to improving patient outcomes with a focus on global health surgery delivery models, and particularly in the LMICs. She has great experience in the public sector in Pakistan and a deep understanding of the many social and institutional barriers that carry on poor access in the provision of quality surgical care, hence her deep and important involvement in the National Surgical Plan for Pakistan. She has also served as chair of the Indus Hospital Research Center. Is also a member of the Permanent Council of the G4 Alliance, in addition to the Global Initiative of Children's Surgery. She's works closely with the Harvard Medical School Center for Global Health Delivery in Dubai, where she's involved in her capacity as faculty in furthering global surgical research in the region. Many of us know Dr. Samad as someone who must be recognized for her numerous talents. But if I have to say something personal, is that very recently, I got to see her through the eyes of one of her trainees, and the respect and admiration is genuine and it's real. So she's not only an incredible professional advocate for patients, but a wonderful mentor. Today, Dr. Samad is also joined by Ms. Arun Fatima, who will join us in the question and answer session. So Dr. Lubna Samad, welcome, the floor is yours.
Ruben, thank you so much for that wonderful introduction. I hope I can live up to it in the next few minutes. So if we can swing straight into the next slide. Okay, so I'll be talking about the NSOAP process in Pakistan and sharing a little bit about our experience there. And really towards the end, discussing and trying to summarize the learnings and the challenges that we've faced to try and see if this can help other people as they either think about or as they're practically going through similar NSOAP processes in their own settings and countries. Next, please. So for those of you who are not familiar with Pakistan, just a quick overview. It's a busy neighborhood with Iran, Afghanistan, China, and India, all neighbors to different sides of Pakistan. The country itself has 4 provinces, Sindh, where Karachi, where I live, is based, Punjab, Khyber Pakhtunkhwa, and Balochistan. And then in addition, there are 3 autonomous territories that do not have provincial devolution of health, Instead, they are controlled by the federal government, and that is the Gilgit-Baltistan area. Really, this is where the Himalayas are, the Azad Jammu Kashmir area, and Islamabad Capital Territory, which is the capital of the country, and that is a federally administered area. What is important to understand from the NSOAP process viewpoint is that the 4 provinces about 12 years ago were given provincial autonomy in most portfolios, including health. So in essence, what our process required us to do was initially engage with the federal government and then work with each province for practical implementation. So it was really not a matter of working with one ministry or one set of government functionaries, but 5, which only added to the fun and the challenge, really. It's a large country with over 200 million people. That's definitely not billion, that's 216 million people, according to the 2019 World Bank estimates. And a large proportion of that is under 15. And that has allowed us to focus on this age group more. It has encouraged us to focus on this age group more as we develop the plans. Next, please. The NSOAP process, you're all very familiar with this, but if we could go to the next, right, so these are the 3 steps that we started off with in our process. It was the ministerial support, the stakeholder engagement, and getting a situation and a baseline assessment, which we started to do in Pakistan. And that really led us to develop the National Vision for Surgical Care 2025. And the reason why we named it a vision and not the traditional NSOAP process is because the National Health Vision for Pakistan is currently in its 10-year cycle. And we wanted to align this and make it a part of the National Health Vision, because Pakistan's NHV does not talk about surgery per se. It mentions NCV, immunizations, maternal and child care, but surgery was really not mentioned in the National Health Vision at all. And therefore, we decided that we would focus on surgery as an addendum to the National Health Vision, which the ministry, the Federal Ministry of Health, kindly agreed to include. They understood that there was a gap, and they were hugely supportive of us from the get-go. We partnered with the WHO's program for surgery, and Walt Johnson was a huge support in helping us get this off the ground in Pakistan, and of course PGSSC. Could we have the next slide, please? And particularly, not only Dr. Mehra, but his entire team of fellows were working with us actively on the ground, were initially part of the consultations that we had with the Ministry of National Health Services Regulation and Coordination, which is the Federal Ministry of Health in Pakistan, a longish name, but means MOH all the same. And then we managed to sign a letter of understanding between the ministry and Indus Health Network. A national steering committee was notified by the government, and a technical working group was created, which included people from Indus Health Network, from the ministry, as well as from PGSSC. And Dr. Iram Fatima was a key part of this because she's based in Islamabad. And it really boils down to pitching up at the ministry every so often, every week or so, and making sure you keep it pushing the agenda forward. And that's what she was really helping us coordinate at that end. We then held a national stakeholders conference in November 2018, after which a consensus statement was drafted. And this consensus statement formed the basis of a document, which was then drafted and presented to the government. The government wanted provincial stakeholders to be engaged, so we went to all 4 provinces to do this. And finally, the National Vision for Surgical Care was created. The aim was to launch this in early 2019. Could we have the next slide, please? And then, so we had this is the meeting in 2018. And just to point out, John came to Islamabad, Walt Johnson was there. We had WHO, the WR is represented there. Dr. Sania Nishtar is the patron for this initiative, as well as Dr. Bari from the Indus Health Network. So we had a wide and senior government as well as non-government interest in this effort. And the next, please, if you could just go through the next couple of pictures. So we then have engagement at every provincial capital. And within a week, we had Alex, Dominique, and Hatham from the PGSCC, along with our own fellows, Iram. Could we have the next couple of pictures as well, please? In which we went on to engage the different provincial governments as well as non-government stakeholders. And finally, we were able to build the consensus across the country that we required. The next slide, please. Now, just to talk about where we faced the delays, the first delay really was at the between initial consultations, some of which actually were held in Geneva with a wider group of interested stakeholders from WFSA. Adrian Gelb was there, Yannicka was there, we had John, Walt, a bunch of people met there with a representative from the Federal Ministry of Health. And we realized that it took a while for those conversations to change into a letter of understanding. And then there was again a delay from when we got the consensus statement to the ministry approving it. We then had a lot of roadblocks. And the reason really was that there were changes at the ministerial level. Governments changed in between, our 5-year election period transpired, and we had to re-engage with a new Minister of Health. And finally, we have now managed to, as of October 12th, get a final but one stage approval for the NVSC document. And one of the main reasons is we got lucky. The initial representative from the Ministry of Health, who met with a number of stakeholders in Geneva in May 2017, became the Director General Health of Pakistan a month or so ago. And just by going up to Islamabad again, talking to him and asking him to help us out, we were able to get the final buy-in. And the next slide, please. So really, the next step was to try and implement it through the provincial surgical, obstetric, and anesthesia plans. But at that time, we had the DCP3 network project start its pilot. Its first pilot globally was done in Pakistan. Next, please. In which they used a consortium between DCP3, the London School, WHO, the Ministry of Health of Pakistan, as well as the Health Analysis Unit. Next slide, please. To go over the, assess the burden of disease data for Pakistan, develop a prioritization process in consultation with stakeholders nationally, cost those prioritized interventions for all 3 levels of care, first, secondary, and tertiary, and then develop a national discourse, which was done this year in February. And finally, we are now implementing this, which is known as the Universal Health Coverage Benefits Package for Pakistan. So rather than engage with the 4 provincial governments, we've sidetracked a little bit and gone ahead and become part of the UHC benefits package, in which the surgical priorities are being managed by our team and our group. Next, please. So in this regard, what we've done is we've identified and adapted some of the original DCP3 218 interventions, of which 44 were surgical procedures. We have given them categorization at which level of healthcare will they be delivered. And for the first time, we've actually specifically created an addendum for pediatric surgical or children's surgical procedures, in which 4 children-specific surgical procedures and 18 addendums were added to the list of surgical procedures. We call them A and B, adult and baby, and that has worked. So really, next slide, please. So what I'm really going to talk about in the last slide is the lessons that we have learned are really, it is so important to adapt As you go along, you have to recognize that NSOAP is a guiding roadmap. It's not set in stone. You have to understand it, adapt it, and run with it. You have to innovate, be ready to think out of the box, tailor specific aspects of the process to your own needs, and you have to be pragmatic. It's important to set the bar high, but don't aim for a pipe dream. Be willing to aim for something that's achievable in your own setting. And again, it's important to be flexible. Listen to your own team, listen to the stakeholders, listen to the bureaucracy. They know how to navigate the systems. And it's important to recognize that we talk about surgical systems. So we have to work within existing frameworks to some extent, break down certain barriers and norms, and navigate the space we have. And persevere, so just don't give up. And despite all the roadblocks, we managed to keep going. It meant a lot of frustration, a lot of trips to the ministries, a lot of phone calls, but just keep going. And lastly, on the next slide, I think it's important to know that it is a teamwork. And I've been lucky to work with a wonderful team, both from Pakistan and abroad internationally. The support has been huge. And I know we are this close to making sure that we get our NSOAP officially launched this year. Thank you so much.
Wow, Lubna, there's really a lot there. And we're going to have to come back to those and many of the topics during our Q&A session, but really just a colossal work on engagement, consensus building, looking into a national vision, and the pearls that you share with us of adaptation, being innovative, pragmatism, flexibility, perseverance, and teamwork are all really sort of critical. Thank you so much for your contributions, and we'll definitely have you asking you questions towards the end of the session. I now want to welcome Dr. Kennedy Lishimpi, who's the Director of Cancer Control, a consultant clinical oncologist and pediatrician with the Ministry of Health of Zambia. Dr. Lishimpi's engagement in clinical services and public health policy are vast. He is responsible for Zambia's cancer health policy and for the translation of that into cancer control programs and the resource mobilization and all the implementation required to support a strategic plan. He was really a pivot in ensuring the improvements and expansions of radiotherapy services in Zambia and has taken institutions from being recipient institutions to institutions that offer assistance to other countries in a very exemplary way. He also has been a very important member of the technical working group that brought us the first National Surgical Obstetrics and Anesthesia Plan delivered after the 2015 resolution, WHA 6815. In the first webinar of the series, we welcome our friend and leader in global surgery, Dr. Emmanuel Makasa, and given the leading role of that Zambia has played in the global surgery community, and as the nation that sponsored the resolution 6815 at the WHO, we are very pleased, and it is a pleasure to welcome Dr. Kennedy Lishimpi to be with us today. So Dr. Lishimpi, the floor is yours. And Dr. Lishimpi, you may be on mute. Sorry.
Yeah, good afternoon or good morning. Thank you very much for having me. And we can go straight into our first slide. Yeah, I'm going to take you through our experience at Zambia. And at the time, I was director for clinical care and diagnostic services at the Ministry of Health. And being an oncologist, I'm very interested in seeing what is the response of this treatment that we have given. So for surgery, I was wondering, where am I going to find what the surgeons have done to look at the perioperative mortality? And when I was plowing through the documents that my predecessor had left, I found this information about the assessments that had been done in the past 5 years about surgery. And when I looked through, I said, this is something we can actually develop into a plan. Unfortunately, that same year, our Minister of Health, can we have the next slide? Our Minister of Health then presented to, you've skipped one. Our Minister of Health presented to the WHO the proposal that we can include this essential and emergency surgery as part of primary health care. Now, in the background, we were actually looking at all these documents. This one, you can see the number of facilities in Zambia. At the time, 2013, we were about almost 2,000. Next slide. And the next slide shows you we had planned so that we have at least 70% of the population with a health center within 5 kilometers of where they live. Next slide. And then when you look at the MDG era, we seem to have done very well in terms of pediatric infant mortality. Next slide. But when you look at the maternal mortality, something was not just right. And when we started to analyze, we began to understand why we could not achieve the MDG target of maternal mortality. Next slide. And like I said, the Minister of Health presented this motion to strengthen emergency and essential surgical care and anesthesia in the context of universal health coverage at the 68th WHO World Health Assembly. And it was supported by 194 countries. And it was a wonderful thing. Next slide. So when the minister came back, he gave us this challenge to say, look, we are the ones who moved the motion, and we need to begin to develop this surgical obstetric and anesthesia plan. Him being a gynecologist himself was very worried about our failure to attain the MDG maternal mortality goal. So when we looked at what was obtaining, we got in touch with the Lancet Commission, we got in touch with the Harvard, and they gave us, they agreed to assist us, and then TET came on board. So we looked at the 6 indicators that the Lancet Commission had published. Can we have the next slide? And we began to see how can we actually translate this for our own country. And we actually looked at what was done already, because there was, next slide, there was a study that was done from about 2011. Can we have the next slide? From about 2011, we were looking at, we were mapping the whole country to look at, you've gone past it, to look at the whole country to see how, where these facilities are that provide surgery, and what are the human resource that is in those places. And in terms of equipment, do we have the appropriate equipment for those hospitals? And then we mapped it, you know, to look at how far are these people, how can people access, and what is the surgical load. So if you give me the next slide, you will see that in this slide, we used the Google map to actually locate all the facilities that had surgical services in Zambia and all other facilities that are available. And then we calculated our 2-hour distance in terms of driving to a first level hospital or higher. So this is what we found. We found that 75% of Zambian population was living within 2 hours of driving distance to a first level hospital or higher. Next slide. And then when you looked at the workforce indicator, when we added the number of anesthesiologists, the number of anesthetists, the number of obstetricians that were available before 2015, that is in 2013, 14, we found our density to be 1.1 per 100,000. The recommended is to have 20 to 40. So you can understand that our country really has a very low number of trained surgeons and anesthesiologists and obstetricians. So already it shows you something. Next slide. So in terms of volume, at that time when we were doing the analysis, there was a 26% of a met need for surgical services, meaning that out of 864,000 cases that needed surgery, only 6,000 actually had surgery done during the time under review. So our met need was about 26%, and we had a huge number of an unmet need. And this also goes to show you that because of the shortages of the few numbers of personnel that should carry out these surgeries, despite us having a large number of hospitals and despite people reaching there in a good time, there is something that is not working properly. Next slide. So finally, this is what we came up with. The 6 indicators were populated, and the only one we didn't have was that peri-operative mortality. And I became very interested when I looked at this, and I said, wow. So it means that we're doing all these operations and we don't know the immediate, the immediate benefit of our patients. What is it that we are doing to them? But in any case, the catastrophic expenditure to surgery was at 56%. And the impoverishment to even cesarean section was about 94%. So next slide. So now, we engaged ourselves in the analysis of this 5-year data, and the Boston-based team joined us, and we together worked. I was appointed by the permanent secretary then to actually lead the process from the Ministry of Health, and we mobilized the partners. The Harvard team came, the TED team came, and we actually had the stakeholders mobilized, and we put everything into context after analyzing the 5-year information that we've been collecting. And we realized that the most important is to create 3 committees. One to address infrastructure, the other one to address workforce, the other one to do information management and financing. And these committees are the terms of reference, and we made sure that they met every week in the time we started. And they were actually putting down technical information. Every week that they met, they had to put down information. Next slide. And our job therefore was to collect this information and to begin to see how we can create a process of the strategic planning to come up with a strategic document that will define the vision, the mission, and the goals of the National Surgical Anesthesia and Obstetric Plan. So in the year 2016, this is what we went through, starting February to October. So between February and April, we were completing the analysis of the data, and all the task forces committees were completing their reports. And in May, we started the writing workshop. We did that, and then we immediately went into the costing workshop. The costing workshop is a cost of all the activities that you identify in your implementation plan during the writing workshop. So it's very important that you actually cost these things so that you can have something to convince the people in finance that you needed this money for these activities. And thereafter, we had the National Surgery and Anesthesia Forum, where all the stakeholders came back again. We presented what we had done with the rest of the surgical teams in the nation. And after it was given a go-ahead by the stakeholders, we then presented it back to the National Ministry of Health, and they agreed to consolidate it as part of the National Health Strategic Plan. And we began now to say, how can we leverage on the partnerships that exist in the country to support these new surgical interventions? Because now everything had to change the way we looked at surgery. We had to ensure that surgery now can be done safely and effectively at primary health, at first level hospitals, meaning the district hospitals. So the bellwether procedures, access to cesarean section, reduction of open fractures, and explorative laparotomy. The country now is able to do them at a district hospital. And we are able to we are now beginning to train a lot more surgeons, even at provincial hospitals. So we engaged partners like COSEXA. COSEXA is a college of Central, South, and Eastern Africa for surgeons that train surgeons. So every surgeon who wants to train under COSEXA then is given a mentor in the country, and that person starts to train. So this is some of the things that came through after the partnership engagement. Next slide. Can we have the next slide, please? Yeah, so what are some of these the dates, in terms of the dates that we had, I went through that already, and this, the picture on top is the, yeah, so this just shows you the timings of what was happening. And the picture on top is the forum, the surgical forum that we had. And the picture below there is the time when we were doing the costing workshop. Next slide. Yeah, so what are some of the key success tips that I could share with my colleagues is that it is very important to have government buy-in, and the leadership is very critical to come from the Ministry of Health itself. And so that after the plan is done, you can have the ownership of this plan by the ministry, and it can be integrated in the process, the processes of the Ministry of Health. These plans must be anchored within the overall country's national health strategic plans, and it should be part of the national priorities. Otherwise, you have a good plan, but if it is not taken as part of national priorities, it won't be funded. And it's important to have partner engagement for both financial and technical supervision and support. And of course, you need to identify local champions. In my case, there were about 3 or so surgeons who are very, very keen to driving the process. And they are still at senior level, and they have actually gotten hold of the plan, and they are beginning to be the supervisors and the people in the forefront of implementation. Some of the challenges that I found were that it requires a lot of commitment from the local people. So people need to understand, and they need to move with you, and you need a lot of meetings. Sometimes you may find 2, 3 people have come, maybe 10 today. So you need to be very, very committed. The next challenge is that it's a reiterative process, and it requires a lot of consensus. Sometimes you discuss something today, the following meeting, another person comes, brings you back what we discussed 3 days ago. So you need to be very patient with people when they are coming to discuss with you. And you need to take all views into consideration. Sometimes, like what happened in Pakistan, leadership changes, top leadership changes, and therefore it can throw the plans into disarray. So you need to ensure that if that happens, you have a way of bringing it back safely. And us being the first time nation of developing such a plan, we really didn't have anything else to look at except, to create what we thought was going to work for us. Little did we know that we were doing it very well. Next slide.
Thank you very, very much, Dr. Lishimpi. A lot there. We're going to jump really quickly, and we do expect to hear some more from you, because there's a lot of pearls in your presentation during the question and answer session. So we have a couple other. So
the Ministry of Health is committed. Yeah, so those are some of the important things. Thank you very much.
Oh, I'm so sorry, Dr. Kendi, I thought you had finished, but yeah, obviously really critical to have the support of the leadership at the top level of the ministry, but also with leaders such as yourself, the ones who accompany you in this journey. I want to introduce my dear friend, Dr. Bisola Onajin-Obayemi, who's the immediate past president of the Nigerian Society of Anesthesia. She's a professor of anesthesiology, the Faculty of Clinical Sciences at College of Health Sciences at the University of Port Harcourt, Nigeria, a consultant anesthesiologist at the teaching hospital in that institution, also council member of the World Federation of Societies of Anesthesiology, and the workforce lead, and a workforce lead in the National Surgical Obstetric and Anesthesia and Nursing Plan for Nigeria. I've had the pleasure of getting to know Dr. Bisola Onajin-Obayemi in her role as the Secretary of the Permanent Council of the Global Alliance for Surgery, Obstetrics, Trauma, and Anesthesia Care. And for those of us who know her, she really is a calming, commanding voice of reason, pragmatism, and unity. Always focused on the task at hand. She's an advisor and an example to us all. Bisola, welcome.
Thank you very much, Ruben, for that wonderful introduction. We'll just dive into my experience writing our NSOAP. Next slide. From the beginning, we had a strategic conversations and which kept on until the launching of our policy 2 years after 21st of May 2019. Now, the next slide will show us the first strategic meeting at Abuja. And this was a deliberate meeting that was packaged by the national, Association of Surgeons of Nigeria, American College of Surgeons, and Trauma Professionals Society of Nigeria. And at this meeting, we had stakeholders like the Nigerian Society of Anesthetists and other professional bodies invited deliberately to come and talk about what is going on in their various professional bodies. Now, by the end of the meeting, we had proposed working groups, and we had 5 working groups. The next slide will show, the next slide, please, will show the next meeting that we had after Abuja. So what went on here was the strategic meeting that went on, that kept going on. We had conversations all through. Can you go on to the next slide, please? That's Jamie Anderson, who was a facilitator at the Abuja meeting. And after that, we met again deliberately at the West African College of Surgeons examination in October 2017. This meeting was intentionally packaged because we knew that many professional leaders were examiners and they would be at that meeting, so it was cost beneficial, and it was an opportunity to sensitize all the surgical specialties, including anesthesia, what is going on, the framework of the NSOAP, and how we had worked so far. The next slide will show us, next slide please, will show the next strategic event that took place. After 1 year of having these meetings, we were recognized and facilitated by the Federal Ministry of Health. We were issued letters as committee members for writing the NSOAP, and that gave us some responsibility and also empowered us to run with the vision. And we also saw that the Federal Ministry of Health had taken ownership and leadership of this policy. So by the time we met at Lagos, the 3rd meeting in Lagos, which was in early in 20, next slide please. Next slide, early in 2018, we had reached out to all the stakeholders at the meeting. And so in 2019, we had all these stakeholders together meeting, and it was, we had a lot of information from different professional bodies. We had reached out also to the Nurse and Midwifery Council, who were represented at the meeting, and they informed us how important it is to have the nurses, midwives, and specialty nurses, surgical specialty nurses involved in this. So it was inclusive in the sense that it now became not just the NSOAP, but it was now the NSOAP, that is the National Surgical Anesthesia and Nursing Plan for Nigeria. The slide you're seeing here shows the second meeting, writing meeting, where we had all the writers together. By this time, we had a lot of information that we had to edit, and this was a deep writing meeting that really tried our concentration and you know, made us, like earlier said, we had a lot of edits to do, cancellation, additions, and stuff like that. The meetings in April were sponsored by the National Postgraduate Medical College of Nigeria. And it was really strategic because the writers were from the different specialties, as well as the Nigerian Journal of Clinical Practice. The chief editor of the journal was there. So at the end of these two writing meetings, we had something that looked like a policy, that looked like a plan. And not only that, apart from the meetings that we had, there were emails back and forth, correcting and editing policy. The next slide shows the policy itself that was launched in May of that 2019, which is last year. So you will see that from the beginning of strategic meetings and coming together and changing the writing together, inclusiveness, including the nurses and the midwives, we had changed from the National Surgical Obstetric and Anesthesia Plan to the NSOAP, which is the National Surgical Obstetric Anesthesia and Nursing Plan. And again, we had a focus on the pediatric age group because the young population in Nigeria was about 62% of the whole population. Just age 0 to 14 years old, demographics shows that we had almost 43% of the population. And so we had a focus on not just the nursing as a workforce, but also pediatric surgery as a special group in Nigeria. So we framed our plan as the strategic priorities for surgical care, planning for a future of equity, safety, and progress. So in summary, the last slide will show that there was a lot of strategic conversation between the professionals. And not only that, you know, they say that if you want to go far, you go alone, but if you want to go, you go together, because if you want to go fast, you go alone, but if you want to go far, you go together. And so we had, right from the beginning, known that we needed to go far, we had to work together, and we deliberately came together. The co-chair, Professor Emmanuel Ame, was experienced. He had been to so many meetings, and he happened to be one of the Lancet commissioners, so he was quite experienced. The Federal Ministry of Health was represented by the Director of Hospital Services, Dr. Joseph Hamedu, and he was also right from the beginning engaged in the process. So we had diversity and inclusiveness. Every specialty was included, and our colleges, postgraduate colleges were included. The West African College of Surgeons, as well as the National Postgraduate Medical College of Nigeria, were also included. And they, by the way, the National Postgraduate College sponsored the 2 deep writings that we had. So the federal government took ownership. We were lucky because we had just one federal government, a powerful government. And at that time, the Minister of Health, Professor Isaac Adewale, was also very, very interested in this plan, bringing it to a success. And we had this deep writing and the distraction-free concentration that helped us to pull all the information together and to clean them up and write a policy that was ready within 2 years of starting the process. It was successfully launched on the 21st of May, 2019. Thank you very much.
Really appreciate your insight as always, Bisola. I'm going to quickly jump, Sam, we're running out of a little bit of time, to introduce Desmond Tanko Jumbam. Mr. Tanko is a health policy analyst from Cameroon, who is currently a health policy consultant for Operation Smile, who's also served as Harvard's Program in Global Social Change Project Coordinator in the Department of Plastic and Oral Surgery at Boston Children's. In addition to his participation in the NSOAP process in Tanzania, he has actually brought us several pieces, such as Investing in Surgery, a value proposition for African leaders, How not to write about global surgery, innovative financing from surgical systems, and sort of tips. And just a few hours ago, he was interviewed by BBC World Service, sort of highlighting his lengthy road and progress from his hometown in Cameroon to being really an advocate and focus on service towards improvement of lives, the condition of people's lives in Cameroon and in many other countries around the world. He is one of the kindest, most humble people you meet, thoughtful beyond belief, and it is really a pleasure to welcome him today. Welcome, Desmond.
Thank you so much, Ruben. I'll be talking about lessons from the development of the Tanzanian NSOAP. Next slide, please. And so I think to begin, there was a slide before this. To begin, I wanted to just give you a high-level overview of the situation in Tanzania, the surgical situation, going off of the 6 Lancet indicators. So with the surgical obstetrician and anesthesia workforce, Tanzania currently has about less than 0.5 per 100,000 population. And that's less than the Lancet target of 20 to 40 by 2030. With regards to surgical volume, Tanzania has about 500 per 100,000 population. Again, significantly less than the 5,000 that the Lancet sets. With regards to surgical risk, the percentage of the population at risk of catastrophic expenditure, there's I think about 70% of the population is at risk of catastrophic expenditure, which again is which is much higher than the Lancet target of 0%. There's currently no data on the percentage of perioperative mortality rates, as well as to our access to surgery. So these are some of the stats that led the Tanzanian Ministry of Health to embark on the development of the National Surgical Plan. And the National Surgical Plan was commissioned by the Ministry of Health, specifically by the Permanent Secretary, Dr. Mpoki, who at the time he still is an anesthesiologist. And he saw that the National Surgical Plan would be the best way to address the issues, surgical challenges in Tanzania in a systematic and coordinated way with all the different stakeholders. This is the NSOAP process at a very high level in Tanzania, and you'll notice the patterns between this process and the Pakistan and the Zambia and Nigerian process. And we're all learning quite a bit from the Zambians who led the process. So the process started in November of 2016 with a comprehensive situation analysis. So there was engagement with over 200 stakeholders from different groups. We interviewed clinicians. This included SAOs and biomedical engineers, midwives, laboratory technicians, but then we also engaged with the civil societies, NGO and end users, as well as government entities. And I should mention that the process in Tanzania was led by Dr. Sarah Maongezi from the Ministry of Health, and Dr. Ntuli Kapologwe from the President's Office for Regional Administration and Local Government. So after the situational analysis, which included a review of published literature on the situation in Tanzania, there was a priority setting workshop that was held in March of the following year with over 70 participants, a 2-day workshop. And the purpose of this workshop was to begin deliberating on what the priorities of the NSOAP should be, what issues should be addressed, and what the targets should be. And this was divided into 5 groups, the domains of the NSOAP. After this priority setting workshop, the priorities of the NSOAP were pretty much set. So we worked very closely with Safe Surgery 2020 and the group from the program in Global Surgery and Social Change to consolidate the priorities into a draft. This draft was then reviewed by a separate writing group that included members of the initial priority setting workshop. And again, it was validated by the broader group. This followed a costing, so the final plan was costed and launched in 2018. Next slide, please. So these are just a few shots. The first shot is from the priority setting workshop. Again, a lot of transparency, a lot of collaboration happening there, an agreement on what the priorities should be. And then in the second writing workshop, the second photo is a writing group, a much smaller group that reviewed the drafts of the NSOAP. Next slide. So the final NSOAP through this process was launched again by the Ministry of Health with Dr. Mpoki pictured there. And the final product was an NSOAP that was first advised by the frontline providers to reflect their needs. Again, and it was written by policymakers, implementers, and funders. It was ambitious, affordable, and attainable, which links back to the pragmatism that Dr. Lubna was talking about, and streamlined with existing policies, which Dr. Lishimpi mentioned as well in his presentation. Next slide. These are the cost of the NSOAP. So at the high level, over 7 years, the anticipated cost is about $500 billion. And this is the breakdown by domain. So infrastructure and workforce are the most costly domains of the Tanzanian NSOAP. Next slide. So these are the 5 most salient lessons from the Tanzanian NSOAP that I would recommend. The first is, I think it goes without saying that the purpose of the NSOAP is not to produce a document, but it's to produce a document that reflects the challenges on the ground and highlights what is going to be done to improve surgical services. And so implementation is key, and political will is paramount for the implementation of an NSOAP. So like was mentioned by the other panelists, it's very important to get the Ministry of Health support and leadership of the process, but also engage with the key stakeholders, such as the parliamentarians and politicians in the process. The second lesson is that the NSOAP must be truly driven by the local stakeholders to reflect their needs. So this is to ensure that the NSOAP, number one, actually addresses issues that surgeons and nurses and other stakeholders face in their daily practice, but it's also to ensure that they have a buy-in of the plan, because they are the ultimate implementers of the plan. Thirdly, you also want to ensure that there's alignment between the national development and ministerial policies. It's not uncommon to see government policies that are at odds with each other. So it's very important to work with the Department of Policy and Planning within the Ministry of Health, but with other ministries to ensure that there's alignment. Fourthly, the NSOAP should be ambitious but attainable. Again, this is very important because there are resources that will be needed to implement the NSOAP. So when you're conducting the costing activity, it's important to ensure that the final cost of the NSOAP is palatable and that it's cost effective. And finally, it's important to engage with the non-state actors, including the private care providers and faith-based organizations, because they have a huge role to play in strengthening surgical services. Those are the main takeaways, the most salient lessons. Thank you very much for listening, and back to you, Ruben.
Thank you very much, Desmond, as always. So we have a few minutes, and I'm going to take the freedom of keeping the Q&A session open for the next 10-15 minutes. It's such rich content. I do want to welcome Irun Fatima, who has joined us with Dr. Lubna Samad. As I mentioned, she has been very, very critical and as a pillar in the Pakistan process, and has been working as a program manager in this initiative, and has many other accolades, but she'll join us in our question and answer session. A couple of points. All of you highlighted at some point that these processes have been led or supported by the government, with the inclusion of many significant players, but it really is important to champion that concept of the ownership by the government. So you all have touched upon that. There are a few questions from the audience that relate to implementation. So we might touch briefly upon that, but please know that there are other webinars of this series that will also be going into implementation. I'm going to just take the freedom to just ask you very, very briefly in a few words to all of you, the panelists, if you have the biggest success from the plans that you presented and the biggest challenge towards the creation of that plan, what would that be? And maybe we can start with Fatima.
Thank you very much. The biggest challenge which I faced throughout the process, and our whole team rather, what we faced was working with the government, the political will, their will to work on this new initiative, accepting the fact that this is an important part, other than the national health vision that they already have, that surgery is a very critical point. It's no more a stepchild. It has to be included. So it is basically, that was the most challenging thing. And similarly, it was a success when we achieved in convincing the government and the provincial governments to come on a forum and talk about surgery, because all these societies, as many of our speakers have mentioned, the Society of Anesthesiologists, the Society of Surgeons, the Pediatric Surgeons, the Society of Orthopedics, they were never brought together on a forum to talk about surgery. So that was our biggest success in all the provinces, plus the national stakeholder meeting that we did.
Excellent, thank you. Lubna, would you like to follow up?
No, Iram did the hard work, so she knows about the challenges far more than I do. But yes, I think what we did see was this eureka moment from the government in which they said, yes, but surgery is important. And we said, we're not there at the national meetings for human resource challenges. We're not there for the prioritization meetings. There is no surgeon on any of the forum. So much so that with the DCP3 process, they had gone through the initial couple of workshops. And then we actually went and said that we're there. We've had a national Vision for Surgical Care stakeholder meeting. You were there at the meeting. Why aren't you calling us to the DCP3 meeting? And they then scrambled around and said, absolutely. So we had 4 surgeons come in and sit in the national consultative process. We had an orthopedic surgeon, a general surgeon, myself as a pediatric surgeon, and an anesthesiologist. So we covered the main areas, and then we got all the societies involved. And what we realized is a lot of people didn't know, but when, that this was something they could get together and promote for their own specialties. But once they did do that, it was, yes, obviously surgery is part of it. So, we saw that transition happening, and that was amazing to know that we'd been part of making that process get started in Pakistan. That was really wonderful.
Thank you, Lubna. Desmond Kennedy of Bisola?
Sure.
Yeah.
I'll go ahead.
Let me go.
Kennedy.
Yeah, sure. Thanks. Our biggest success, I think, was the support from the minister's office. I think that gave us a lot of impetus. So because of that, the permanent secretary quickly gave me that responsibility that I should run. And then we appointed the team to work, the team of surgeons that really assisted. Yeah, so that I found to be the biggest weapon in this process to get high level buy-in. The biggest challenge though was to keep these teams together and working, because from April all the way to October, it's about 8 months or so. They have a lot of things to do in the hospital. And the worst thing you can do to a specialist is to pick him up and start talking to him about health system strengthening and universal health coverage. Once they know they want to go and operate, it was very hard to keep them together, but somehow we did it. But that's a challenge that I found, that this one, it's not easy to keep surgeons in the same group.
About the time too. Bisola?
I would start with a challenge. The challenge was finance. Where do we get the money from to get ourselves together to write this? But in spite of that, we just decided to start working, you know. But our biggest success are the people. We had the right people who were passionate, who were so involving, and we had the right framework. We were not working in silos, probably because our national colleges had been together, like the Nigerian Postgraduate Medical College, you know, had a faculty of anesthesia, faculty of surgery, you know, different faculties together in the same college, nationally and regionally as well. We also had the West African College of Surgeons working right from the beginning with the faculty of anesthesia in the regional college, the West African College of Surgeons. So we did not have a problem with getting everybody on board. So our people, and our people also includes the people in the Federal Ministry of Health, and all our stakeholders were our biggest success. We worked together passionately. Yeah.
Standing, Bisola. Desmond?
Sure. I'll give a challenge and a half. The first challenge was the funding. Like Dr. Bisola said, you know, it's great to have a plan, but if there's no money to implement it, it's not going to be implemented. And so that had been a challenge in, you know, how do we continuously engage with the government to ensure that when the plan is actually completed, there's going to be some resources allocated to that, but also working very closely with external funders like the World Bank. So we had several meetings with the World Bank throughout the process, engaged with USAID, and we had invitations from the Development Partners Group, which is a conglomerate of funders, from external funders that meets regularly in the country. So that had been a challenge. The other half of a challenge is, again, coordinating different stakeholders with different views, especially around contentious issues like task sharing, task shifting. So, you know, if you're leading an NSOAP process, you have to have the skill to be able to manage and coordinate these different views. The one success that I would lay out is, again, in agreement with everyone, are the champions within and outside of the Ministry of Health. So within the Ministry of Health, it was crucial to have people like Dr. Sarah leading the process, but also within other departments of the Ministry of Health, because, you know, Dr. Mpoki, who led the process, who commissioned the NSOAP, is now an ambassador to Canada, right? And so if all the weight of the NSOAP was on him, then after it left, you know, it would be hard to keep it moving. But then outside the Ministry of Health, we had professional societies who were also very passionate about the NSOAP and continue to ensure that we move it forward in the implementation.
Thank you so much, Desmond. I'm going to actually continue with you and put you back on spot. And I'm going to ask the panelists to answer very succinctly, just one or two sentences. If you were to have a chance to do this all over again, what would you do differently?
Thanks for starting with me. If I had a chance to do it differently, I think, again, it goes back, relating back to the challenge that I mentioned around funding. It's crucial to ensure that you engage funders from the very beginning and perhaps even before you begin the NSOAP process, to ensure that they're on board and that they provide their input on the contents of the NSOAP. So that's what I would advise other countries and would do differently in Tanzania.
Thanks, Desmond. And I asked a question because there are many people in the audience who are in the position of starting some of these processes in their own countries. To learn, want to learn from you. Dr. Kennedy, your insight, what would you do differently?
Ruben, I think it's rather difficult for me, who was in the process, to think I would have done it differently than another person looking at us. But what I think is that I also was at the same time looking at the national healthcare packages for the country. So I was chairing that committee as well. So it was so easy for me to put the surgical plans in that perspective, looking at how the country's health system was evolving. So we need to prepare each section to be able to join in and fit in the basic healthcare packages that are being created for each level of service. So at that point, I could see both sides of policy as well as service delivery. So you need to have information. That's the only thing that I can say for now. How I would have done it differently, maybe I need to think again. But I think the process we followed was quite rigorous, and it gave us quite good information to produce a good plan.
Outstanding, Dr. Lishimpi. So I know that Jeff is back online, which means we're almost out of time to wrap it up, but I would love to hear from Lubna, Iram, and Bisola if we have a couple more minutes.
If I was given the opportunity to do it again, I will do the same thing all over again. Because
Nice.
Now, with hindsight, I can see that we have such amazing capabilities when we work together. We pushed, ourselves to the limit. And maybe one thing, I'm going to do differently is to talk about it, let it be in the news. Because when we were writing this thing, we never knew that the outcome would be so good. And I'm really, really proud of every member, every committee member, every writer, and also our champions, the Federal Ministry of Health. Yeah.
Bisola.
Ruben?
Thank you. Lubna?
So I think we're not really at the end of our process yet. I think we were very lucky because the engagement with the ministries, however willing they are to help out and however much in agreement they are with our purpose, the engagement with ministries is difficult. To engage 4 additional ministries was scary, I'm being very honest. So in some ways, the DCP3 process, providing a UHC platform of which surgery was inherently a part, was probably the best thing that could have happened to us. So if we had planned, we would have gone the provincial plan route, but this was very lucky. I think Iram is going to add on another point about, a retrospective one, but I'll let her add that bit. But I think we were very lucky with the timing because engaging with 4 additional governments would really have been very difficult.
Thank you, Lubna. Iram?
Thank you, Dr. Lubna. To add on is, if we could redo something, or it would be best that if we involved at the national health planning level or the strategic development when the national health plan is being made. So if we had a chance, we would have jumped in at that time so that it's inclusive. We had no other choice. The way we worked with the national ministry and then the provincial, and then this DCP3 thing came, as Dr. Lubna mentioned. So that helped us a lot. I would only, I think, follow the same process, but more to have insight and more efforts at the planning level, strategic planning, when national health planning is being made. I think that's the best point to that I could do if I had to redo it.
Outstanding. Thank you so much, Iram. Great insight. The one thing I can say is this type of sessions just leave us hungry for more. So I wish we had a couple more hours. I'm gonna just read a couple more questions just so that you keep in mind the type of thoughts that are going through our audience. And I'm going to ask the audience to keep those questions in mind, because those questions are going to continue to be addressed throughout this webinar series. So today, this is second, there's more opportunities to go into some of these topics, but, and some of you have put your email addresses on the chat, and I'm sure some of the audience members will be reaching out to you. But there are questions as it relates to how can NSOAPs help effectively train more members of the surgical team. There are questions that relate to what accountability systems are in place to ensure that the findings and the process do not kind of lie fallow, or that the expectations are not, or the hopes are not met. And there are questions of how do we engage the younger leaders, medical students as significant stakeholders in progress towards the future. These are some of the questions that we're receiving from Noel, from Gaso, Kate, from Smile, Bani, Fagli, Adidi, Adin Kemelu, and so many others. So there's room for more, but for now, I'll just turn it over to Jeff with our gratitude on behalf of Operation Smile for allowing us to join UNITAR Global Surgery Foundation, our friends at PGSSC, and to join in support with Johnson & Johnson for this fantastic session. Jeff, thank you so much for the opportunity.
Well, thank you, Ruben, and thank you to all the panelists. This has been such a great session, and in fact, I really wish we could just keep going. The discussions have been so good. And like Ruben was saying, some of the questions that have come out of the participants about, one here about how do you navigate when a government keeps changing, and you've developed a relationship with one set of government leaders, and then it changes to a different set. And really, some of these challenges can really be daunting. But I think that the key word is relationships on multiple levels of government, not only on the elected politicians, but on those civil servants who don't change between governments, and really get their buy-in on some of these important points. The other question that keeps coming up is, what about implementation, and how do you finance implementation? And this has been the sort of the holy grail of NSOAPs, is how do we get to that point of implementing an NSOAP? And I know that the PGSSC and others alongside have been working on plans on how do you do this rate for it. But I think having the Ministry of Finance and the donors and funders engaged at the early stages of an NSOAP seems to be a logical step forward in terms of some of the implementation financing questions. But I just want to say that thank you again to all of our panelists for such excellent talks. This session will be is being recorded and will be online by tomorrow, and so can be referenced and watched again. And we're quite happy to reach out to anyone who is interested in further questions. And the other point is that this is just the second of 6 more webinars on different topics, and the next one is 2 weeks from now, and it is on the integration of NSOAPs into the national health strategies. And we've all been hearing the same message. This is not to be a standalone plan. This is a plan that needs to be integrated very well into the national health strategies. And so that's the next session, and then we have sessions on donor perspective, Ministry of Health perspective, the roles of NGOs, professional societies, and academic centers. And then we're gonna finish off this series in the new year with a session on what are the next steps? How do you kickstart this process? So I really welcome you to join in on all these sessions and hear the expert content specialists speak to those topics. So Ruben, thank you to you, and I see that Kate's also on the line from Operation Smile for co-sponsoring this session. Thank you to the group at PGSSC, and I just want to recognize Key Park, who's also on the line, to the whole team at Harvard for this, and to all the panelists, and in particular, the teams that are represented behind each of you on this panel today. As you have all highlighted, it's not a one-person show, it's a whole team effort. And I just want to recognize all of the teams that have been involved in the processes in all of your countries. So very good job, guys. And I really look forward to seeing the next steps as we move forward. So a very warm thank you from the United Nations United Nations Institute for Training and Research and the Global Surgery Foundation. And we welcome you to the next sessions. Thank you very much and goodbye.
Thank you.